Hello, my name is Sarah and I'm a fourth year medical student. Today I'll be doing a presentation on laparoscopic radical nephrectomy. So this is an overview of what I'll cover today. To start with, I'll just briefly go over the main indications of this surgery, the equipment that is required throughout, and then a step-by-step through the surgery, including pre-operative and post-operative care as well. Due to the anatomical differences, left and right nephrectomies are performed slightly differently. When this is the case, I'll discuss the right nephrectomy first and then mention how the left would be performed. Indications for surgery. The removal of a kidney is most often required due to the presence of renal cell carcinoma. This surgery is indicated when it classifies as a T1 tumour of less than 7 cm or a T2 tumour of more than 7 cm but limited to the kidney. These may be cystic or solid renal masses. Partial nephrectomies are also common, however, due to there being differences in procedure, I won't go through this today in this presentation. This is a general equipment list. It's not completely exhaustive, but it does give a good representation of the equipment that is required throughout the surgery. I won't go through them now, as I will be mentioning some of them as I go through the steps of the surgery. However, I would like to highlight that both bipolar and harmonic devices can be used for this procedure. Before the procedure begins, the patient will need to be consented. This will include an overview of the surgery and its benefits, as well as the risks and possible complications that may occur. The patient will also be asked not to eat for 6 hours before the surgery and to only drink clear fluids up to 2 hours before the surgery. Once consented, they can be prepped for surgery by taking bloods, especially including group and save, as well as urinalysis, pregnancy test and an ECG. At this point, the patient will be given stockings to reduce the risk of DVT. This surgery requires general anaesthetic, so they'll also need to be consented for this and prepped for this as well. In terms of room setup, many urology surgeries are done on a C-arm operating table. This isn't specific to this procedure, however, it is the most likely that will be used. This surgery is often done via a transperitoneal subcostal approach, where the patient is placed in a 45 degrees modified flank position where the iliac crest is the highest point of the patient. At this point, I'd also like to mention that an integrated setup may be preferable, however, a more common stack setup may also be used. So in terms of ports, these are the most commonly used port placements. However, this can vary on certain factors, such as if the patient is obese, has had previous surgery, or if they are tall, where the port placement may need to be changed slightly. For the right nephrectomy, the first port is a 12mm port in the umbilicus, or just lateral to this. Then a 5 to 12mm trocar is then placed midway between the umbilicus and the xiphoid process, and a third is placed laterally to the umbilical port at the edge of the rectus abdominis, as seen in this image. Finally, a 5mm trocar can also be placed laterally at the axillary line below the rib cage, and this can allow for easier retraction of the liver, but is not always necessary. For the left nephrectomy, again start with a 12mm port at the umbilicus. The second is a 5 to 12mm trocar placed lateral to the umbilical port at the edge of the rectus abdominis, and the final port being placed midway between the umbilicus and the xiphoid process. Once you have access to the abdomen, the first step is to mobilize the colon. Initially, you want to identify the lateral line of Tolt. This is the lateral peritoneal reflection along the outer edge of the ascending and descending colon. This can then be used to medially reflect the colon across the midline by dividing the colorenal ligament. This is the Cattle maneuver, and then once this step is completed, the duodenum should also be rolled medially to allow you to visualize the inferior vena cava, and this is known as the Kocher maneuver. The triangular ligament and part of the anterior coronary ligament of the liver can then be divided to allow you to visualize the upper pole of the kidney. For a left nephrectomy, the initial steps of identifying the lateral line of Tolt and reflecting the colon are done in the same way. However, at this point it will be necessary to divide the phrenicocholic, splenocholic, and splenorenal ligaments to visualize the inferior vena cava. The next step is to identify the gonadal vein and the ureter. This can be gained through various methods, including using anatomical awareness, observing peristalsis, which can be initiated with the end of some forceps, and through a colour difference of the gonadal veins, with the veins being more blue than the ureter. Once identified, follow the ureter and gonadal vein up to the lower pole of the kidney, as well as the hilum, which will be slightly superior to this. Again, the first few steps for a left nephrectomy are very similar. However, once the gonadal vein has been identified, it can be followed up to the left renal vein, where it will require dissection using two 5mm clips before the point of drainage into the left renal vein. At this point, in both right and left nephrectomies, the lower pole of the kidney can then be dissected from the psoas muscle or the posterior wall. The third step is renal hilar dissection. So you'll need to identify the renal vein by using a grasper to move the kidney laterally and superiorly so that the planes can be dissected. If this is not working, use a suture to laterally retract the ureter and the kidney. On the right side, the renal vein can be isolated and both the renal artery and vein can then be dissected, making sure to dissect the artery first to reduce the risk of hemorrhagic injury to the kidney. Once again, the process is very similar on the left, and the only difference is the addition of identifying the adrenal and lumbar veins, which should be dissected before proceeding to the renal artery and renal vein. The fourth step is to dissect any remaining renal attachments. So at this point, the kidney is nearly isolated and there are just a few other attachments that need to be removed. This includes using blunt dissection to detach the adrenal gland from the superior pole and to dissect the lateral attachments to the kidney body. Finally, the ureter is transected with two 5mm clips to completely isolate the kidney. Before removal from the abdomen, the kidney can be placed on the liver or spleen, whilst the abdomen is examined for any bleeding. This can be done through making sure that any irrigation comes back clear and that the surgeons are confident that all blood vessels are secure. Removal of the kidney can then be done in several ways, either through morcellation, where you'd cut the kidney into smaller pieces and remove it through the ports, or by removing it whole through increasing the incision size, or the preferred method of the Pfannenstein method, where an incision is produced just above the pubic bone. Once this is completed, the patient can be closed by removing the ports under vision. It should be noted that the umbilical port should be done last, with the camera being used to view the intestines as the abdomen is deflated, to ensure that none is drawn into the port site. These can then be sutured and covered. As with any surgery, complications can occur, and I've listed the main ones here, being hemorrhages resulting from damage to the aorta, inferior vena cava or other small blood vessels, damage to the surrounding structures, most commonly the spleen, liver, pancreas and bowel, and finally anaesthetic risks such as damage to teeth, throat and larynx, reaction to medication, post-procedural nausea and vomiting, cardiovascular and respiratory complications as well. Post-operative complications normally include pain, infection of the surgical sites or intra-abdominally, and also blood clots, and these should all be discussed with the patient before the procedure. In terms of possible long-term complications, the patient may develop incisional hernia, chronic kidney disease, or disease recurrence. I will now just run through post-operative care. So recovery normally takes 2 to 3 days, and during this time the patient is given pain management and observations are taken at regular intervals to ensure that there are no post-operative complications. Initially, the pain management is through a patient-controlled pump and then via tablets. On the second day post-op, the patient can graduate from a liquid diet to a regular diet and the catheter can be removed. Once they are assessed as fit for discharge, the patient is free to go home. In terms of long-term management, it's normally relatively simple where no complications have arisen during the surgery, and patients should expect to return to full activity within 3 to 4 weeks, with one follow-up 1 month after the operation. The patient should also be advised not to drive for 2 to 3 weeks, however, this is up to their discretion. So just to summarise the main points, a radical nephrectomy is a minimally invasive surgery to remove a whole kidney with the patient placed in a 45-degree flank position under general anaesthesia. The main steps are to mobilise the colon, identify the ureter and gonadal vein, hilate dissection, dissection of all other renal attachments, and then finally removal from the abdomen. Post-operative care will involve making sure that the patient recovers well and treat any potential complications that may have arisen during or after the surgery. This is just a list of the main references, and I've included them in case you want to look into this surgery further. Thank you for listening.